This is the Mechanical Care Forum, episode 397. It's season 13, and we're highlighting the McKinsey Institute International Diploma Program. We're checking back in with two of this year's candidates, Tina and Tui, as they experience yet another component, the clinical residency. 360 hours of practical time in the clinic under the mentoring of the clinical tutors, Claus and Annette. This week on MCF. Hey everyone, welcome back. Thanks for joining us today as we continue to explore the McKinsey Institute International's Diploma Program, this season, season 13 on the podcast. This episode is brought to you by the McKinsey Institute International. The McKinsey method of mechanical diagnosis and therapy is globally recognized as a leading treatment for back, neck, and extremity disorders. In my personal experience, MDT has made the single greatest positive influence on my practice, hands down. The McKinsey Institute International offers this diploma program to those professionals who have achieved prior certification in the method. It's the pinnacle of MDT training. Successfully completing the diploma program will place you amongst the world's elite in mechanical diagnosis and therapy. If you're interested in learning more, here are a couple of ways. First, stay tuned today and be sure to follow us all through the season, season 13, as we highlight this year's cohort of students through the program and get perspectives from this year's group of candidates, from some of the instructors, from some of the clinical tutors on the residencies, and more. And second, be sure to go to the website to learn more about the program and how to apply, which you'll find by clicking on the Education tab and scrolling down to International Diploma. Just go to mckinseyinstitute.org. So we've already introduced you to this year's cohort of diploma candidates. We've spoken with Helen Clare, the CEO of the McKinsey Institute International, and Richard Rosedale, the Director of Education and the coordinator of the diploma program itself. We've spoken to three recent graduates, now diplomats. We've checked back in with my classmates, talking with three of the clinical instructors as well within that theoretical portion. And most recently, we checked back in with my classmates as well following the completion of the theoretical portion, as we've successfully accomplished that first piece. In today's episode 397, you'll hear Tina and Tui share how they're doing, now 7 weeks into their clinical residency, how their clinical reasoning has developed, and where they still feel they need improvement. You'll also hear Claus and Annette clarify their primary role, how the days are structured, and more. Do stay with us through to the end to hear what's coming in future episodes. So here we go. Here is episode 397. Enjoy. So with us today, the Mechanical Care Forum, we're pleased to welcome a group of 4 from Denmark, 2 instructors, 2 students, one that you already know, Tina, and thanks for being back with us. But Annette, Claus, Tui, thanks for joining the podcast. Welcome.
Thank you.
Thank you.
Thank you.
So let's just start with introductions, since 3 of you are new to those that are listening. First, Claus and Annette, why don't you guys share just a bit about where you're from, your clinical setting in normal, everyday, routine work, what else you're doing outside of clinical work, perhaps, and then we'll get into specifics on what you guys are doing there with this clinical residency. So Annette, why don't you start?
Yeah, well, I'm Annette, and I'm from Aarhus in Denmark, and I'm working here in Skanderborg, and it's a back spine clinic, but we also see a lot of extremities, mostly insurance people come, and I'm working here with Claus, and I have been doing it for the last 2.5 years now. And I took my diploma in 21. So I'm rather new to this. And so next to the clinic, I started probationary training for teaching the McKinsey courses. So I have been doing that for 8-9 months now. So that's also very rewarding in many ways, but this is a different way of teaching. So yeah.
Excellent. Annette, just real briefly, talk to us a bit about what you were doing before MDT. Did you learn it right out of your physio school, or was it much later?
Well, I graduated in 2010 and started working with Claus in another clinic. And he was just finishing his diploma at that point. So I was very inspired. So right after school, I was just on the McKinsey courses.
Okay.
It took the credential in 2012. So have been doing this for quite some time now. But it took some time for me to take the diploma. because of there was some some money and time off family. So after that, I got 3 kids, and then they grew up, so they can, yeah, it fits to the family. They were older, and yeah.
Got it. Okay. Yeah. So timing was your situation. You may have wanted to do it earlier, but it wasn't the right time.
Timing and money, I think. So it would have been easier to do it before children and all that. Yeah.
Yep. Yep. It's a
Mhm.
common thing that we hear from a lot of
Yeah.
people. So yeah, we can appreciate that. Klaus, tell us a little bit about yourself as well, and your role and what else you're doing outside of the residency.
Yeah. Well, first off, this is a pretty large setting. There is a big fitness studio, a big gym with 1,500 members. Then Annette and I have a spine care clinic together. There is a sports clinic as well. And then we have a very large setting with what you could call NHS patients. So people who get some payback from the government. So what Annette and I do is all private, and then we have the other stuff. So when we do this with the candidates, we can pick and choose from every patient coming in, because otherwise it would be primarily spine patients. So we see loads of stuff. It's a fairly big house. For me personally, I took the diploma in 2010, started off teaching the MDT courses 1 or 2 years later, been teaching them for years. I've only done one diploma setting a couple of years ago, and then this one. So the last time was actually Annette. She was there alone. This is the first time with 2 people, which is a major positive, I think.
Yeah.
So you can definitely do it alone, but being 2 is a positive thing, I think. Yeah.
Yeah. Yeah. Excellent. Well, thanks, guys, for explaining the situation in the clinic setting. Tui, you're new to those that are listening, just compared to some of our other cohort in this year's diploma candidate group. So tell us a little bit about yourself, your clinical work in the past, where you're from, and your normal clinic setting, all those things.
Yeah. Thanks, Jason. Well, I live in Aalborg, which is in the northern part of Denmark, and work in a small municipality called Jammerbugt Kommune, very small and unknown for the most. Primarily, I see patients coming from hospital with spine and shoulder injuries, and then, some of all body parts as well, but mainly spine and shoulder. Started my MDT adventure in 2015 with my Part A course, and then I went into the credential in 2019, and then started the diploma in the beginning of this year, 2023. So it's been a long journey, but it sure is rewarding as well. So now we are here. My antenna is going through the 7th week, and I think we are progressing quite well, if I may say so, on the behalf of you, Tina, as well. And I love it. It's very rewarding. It's great. It's with a huge quality from both Claus and Annette. And I think the clinical reasoning is really getting me a huge push forward regarding how to manage patients in everyday work life.
Mm-hmm. Yeah, the listeners have gotten a good idea of some of the reasons why some of our classmates have decided to go through this significant financial investment and time investment, like Annette, you were mentioning, to go through the diploma program. But what was your reasoning? What were you seeing in your practice or just in your thought process with patients that really persuaded you to consider this?
Well, I think I've been a physical therapist for 13 years, and throughout the first 7-8 years, I went to a lot of different courses and also got qualified in a higher level at some of them. But the first time I ran into the MDT assessment and the MDT structure, it just gave me the thoroughness of the way to assess patients and get response from it from first to a third and fourth and fifth session with them. It was a different way to get a classification system to manage and handle patients that doesn't fit into any other boxes as well. So that was inspiring me very much. And I think that was the primary reason to keep going in that direction. And also the thoroughness bring you towards a conclusion of some of the patients that we can't help. So this can be explained better through the McKinsey system as well.
Yeah. Yeah, excellent. Yeah, it's a similar story from a lot of us, I think, but we're grateful that you're part of it this year. Of course, Tina, most are familiar with you just from previous episodes, hearing kind of your background. How's it going? Let me just let you kind of break the ice here. How are things with this first 7 weeks, and where's your mindset? I know that after the theoretical, there was thoughts in your mind about, gosh, is this really worth all the time and the money? Or is my thinking really that much advanced yet? Where are you just initially right now?
Well, I definitely have grown in my skills with the patients. I think the clinical reasoning has developed. And so, yeah, for sure, the clinical part here has taken a big step further.
Yes. Okay.
Yeah.
All right. I knew that was a concern of yours. It's always nice to kind of see us go through this process. And some talk about it was one patient on week 3, or it was 1 week or a module from the theoretical that really started changing it. But for you, it sounds like things have started to come together in terms of that, I guess, reward for all of this time and effort you're putting toward it.
Mm-hmm. Yeah, definitely.
Yeah. Claus and Annette, let's go back to you guys for a moment. I want to understand from your perspective what your intent is. Tell us about the format for Tui and Tina in this clinical residency. Annette, why don't you start just from your own perspective? What's your intention or hopes for Tui and Tina going through this, and talk about the format a bit?
Well, my intention with this is not to give all the answers, but be a facilitator to make them do the clinical reasoning themselves and lift them on a higher level from where they start and where they should end. To make them reflect on each patient situation, but you can also come at a point where you need just the right answer, or what would you do in this situation, and also give them that. So that's kind of a balance, I think. So the format here is that Tua and Tina, they see patients. We are one educator per day. So I have 2 days and Claus has 3 days. And there are 2 students, so we cannot be 2 places at once. So if they have patients at the same time, we go a bit back and forth. And also, well, in the beginning, they could not have patients at the same time. We were supervising all the time. And then after maybe that was week 3, I think, they could have patients at the same time. And then we discuss the plan before they go into the patient, see the patient, and discuss it. And what if the patient is worse? What if the patient is better? Or what if the patient there's no effect of the treatment? So they have been reflecting on the situation before they see the patient. And then we will follow up afterwards. How did it go? And what did I see? They should also do some self-reflection of, is there anything they could have done differently, and also focus on what they have been doing well in that patient setting. Yeah. So it's not only just about finding the flaws and things that you can do different. It's also recognizing the good thing they do. Yeah.
Yeah, excellent. Claus, what would you add to that? What are you hearing from Annette that you would want to clarify or expound upon?
He pretty much sums it up. But for the first 3 weeks, we would like to see every patient with Tua and Tina. It's not that we don't trust them, but just to kick off the process. Then afterwards, we have meetings in the morning or in the afternoons, and we plan the day. So in the morning, we can discuss which patients are we going to see, what's the plan. If they see patients at the same time, do they have some specific patients where they would like us to be in the room? So I think it's more like a cooperation on it. So we would like to see 2-3 patient scenarios with them every day and give them some feedback. But yeah, it depends on the daily schedule. When we're in the room with them, we do the best we can to be a sparring partner and not somebody on the neck trying to see what's wrong. But I remember from my own diploma, you have to get used to people who want to help you. Nobody's trying to pick all the flaws. It's a matter of helping, but you got to find your own way in it.
Yes.
Yeah.
You mentioned that you've done this once with Annette when she was going through it, that this is the first time you've had a couple. What are you and Annette learning through this process of maybe how that might affect your future working with diploma candidates?
To be honest, I think we haven't seen any big surprises because we talked about it beforehand that assisting people on learning stuff is really hard. Nobody expects it to be easy. It's not easy being an instructor. So when you go into that room and you see, let's see, 10 good things, 10 minor things that you can adjust, 2 or 3 things you want to adjust, and you go out afterwards, then you have to pick and choose what do you say because you can't comprehend it all. So you have to start off from somewhere. I think it's hard.
Yeah.
I think it's very hard because we know all the MDT basics. That's not hard. That's what we do every day.
Mm-hmm.
But assisting people in their learning process is really hard.
Yeah.
And in the end, I don't think we can make people learn anything. We can assist them in thinking, reasoning, and they have to comprehend it themselves. It's an active learning process.
Yeah.
I think it's hard.
Yeah. Yeah. I remember talking to Chris and Kim just recently when I finished up with my clinical residency as well in Texas, here in the U.S. And I said, boy, this must be tiring for you guys to have someone over your shoulder all the time. And not that Tui and Tina are just overbearing and tiresome, but just having someone that you're responsible for to some degree. Annette, do you agree with that it is somewhat fatiguing?
Yeah, I think it's hard. But I also find it more rewarding and more than I thought it would be, because I like Tu and Tina as persons, and we have spent so many hours together. And Tina and Tu, they were also with Claus and I on parts C and D in Plaitas, where we had many hours together, and that was a great experience as well. So I think it's been fun. And I would like to do it again if it's possible sometime, but it's also very tiring and hard. Yeah, I think it's but not as much as what Tina and Tu are going through right now.
Sure.
But Claus and I also have something to prepare for each day, but the load of that is minor to what Tina and Tu are going through right now. Yeah.
Sure. Yeah, I told Chris and Kim that I was disappointed that I didn't get to go to a resort on an island. Yeah. So, Tui, talk about your experience a bit. You're hearing Claus and Annette talk about their responsibilities and the load that they have, and you hear Annette mention that it's not but just a small portion of what the load for you. How has it been? Has it been pretty overwhelming, or do they need to add more to what you're doing just to make it more challenging for you?
Well, I think it's sure is quite challenging and quite disturbing to know that Claus is leaving 7 to 8 other not mentioned things that could be potential better. So I'll have that in mind next time he's sitting in the corner of the treatment room. No, just on the serious note, it's very time consuming for sure. We are here at normal work hours and got some driving for me. I decided to use some hours in the car to get home to my family as well. And that's great to feel connected throughout the 9 weeks with the family, but it's also time consuming due to the hours I need to use to prepare patients and read articles and prepare the theoretical stuff that we also work with during the 9 weeks here. Mm-hmm. So I think in some kind of work hours, we are here like 35 hours a week, and I use at least 2 hours every night in every days, in the normal days, Monday to Friday, and then also some more hours during the weekend. I would say at least 6-7 hours every weekend as well. So that's one part of it, that just the hours that we have to use. But the other part is that your mind and your thinking is just keep going into these MDT stuff all the time. So even when you're not doing it, you're still thinking, should I have done that in a different way, or could I think of that in another way? How about that exercise? Was that a bad choice? And stuff like that. So it's just a mindset, and even more in the clinical than in the theoretical. I think the theoretical was tough as well, but in the clinical here, we are seeing the patients, we are getting the bonus from all the hard work. It's really here where it all makes sense. So it's great, but it's rough.
Yeah. How long does it take you? How many minutes or hours does it take you to commute every day?
My drive house, like 1.5 each way, so 3 hours every day.
Okay, got it. Yeah, just to give people an idea of how that's working for you. Tina, talk a little bit about your day. Walk us through what you're doing and when you're seeing patients, and then what you're doing after hours. So just give us a standard weekday understanding of what your day looks like.
Yeah, we usually meet here at 8:30, and either you see a patient right away or perhaps half an hour later, and then we see patients during the day, and we schedule them ourselves unless the new ones they are scheduled by the secretary. And then it's sometimes you're having a lot of patients during that day, and sometimes you're having less, but you always have something to work on, because you can always write something or read something or just dig into one of the tasks that Annette and Claus has been talking about. So there's always a lot of stuff to do. We have a break during the day where we eat together with all the other physios here in this place. I think they're about 20 all in all, or so, something like that. Yeah. And they have been very welcoming, I think, and that's been nice that we're feeling a part of this clinic. And then later in the afternoon, we are having patients again, and we have to read and write again. And around 3:00, we get home. But as Tu is saying, then there's a lot of work to do. And I'm staying here in this town overnight. And I think I spent about 4 or 5 hours a day, just preparation for the next day, or just writing and reading, and then there's also a lot of hours during the weekend. We usually have a task for each week to prepare for the next week, to do a presentation during, it could be either Thursday or Friday every week. We do this presentation for Annette and Claus only.
Yeah, we appreciate you guys speaking English to us today. I know it's probably hard to switch over when you're talking all day in Danish. Tina, that was something that was really tough on you, I think, during the theoretical, was having to communicate and make your comments in English and read all these papers and all. Has that been a part of why maybe you're feeling that this is so rewarding now, is because you can speak in your primary language?
Yeah, and it's not only the language, it's the culture as well. Because, I mean, when you with your own culture, you kind of understand what is said and what is not said, and that can be really hard in another culture. So that's I was really arguing to do this clinical part in my own country. I don't think it has anything to do in how much I feel I have developed. I think I would have had the same feeling even if I had been abroad. But for sure, it's much more easy just to talk every day with each other. And the funny thing is that we are not only talking Danish. I mean, we're talking English some of the time, because just the words we use in MDT system, we still use the English parts here.
I see. Okay, That's interesting. Yeah. Very good. So let's talk about a patient or two. Maybe, Tui, it's one that you were with, either Claus or Annette, and you thought, I didn't come to that same conclusion that you're telling me that you're coming to, or I don't think that we're going to determine that this is a derangement, or yes, it is, and they have a differing opinion. Can you think of one in your mind? Give us just a quick little idea of the patient maybe, and then let's talk about just your thought process through that patient.
I think I got one. It was a male. Annette, you was with him. It was a spinal patient in the lower part of the spine, and he turned out to be a mechanical unresponsive radicular syndrome. It was the one that would like to book his own appointment in the future. Do you recognize him, Annette? Yeah. And I think from the first visit, I assessed him and found him like he could be a derangement, but it wasn't sure. So we have to test it off with repeated movement. And so I did. And at the first appointment, we both tried the extension and the flexion with all the forces. and he was sent home with flexion. And at the second appointment, he got back, and Annette was, he is most likely mechanical unresponsive radicular syndrome. And I was just like, but I have to test the derangement to be sure. And I went into extension with hips off to prove that he wasn't a derangement, and he wasn't. So yeah, and he wasn't happy with the hips off exercise. So I think Annette got larger amount of recognition in towards the pattern. And yeah, she did see that before me, but that's a kind of the process. And
yeah. Tui, what were you seeing in the patient that made you think, I've got to pursue this a little more before I can feel comfortable thinking that it's MURS versus a derangement?
First off, it was one of the first weeks we were here. So it has to be said that a lot has happened since that, which was the clinical reasoning. But I think it was more like, we talked a lot about the flexion, extension, side glide and standing, the clock, where we have to test all the ways around the clock to be sure that it isn't a derangement. So that was practically what I went in and did that day. But yeah, he just got an increase in his pain and was worse afterwards. So it wasn't the case. And then we turned back to the flexion and rotation, where he got more space in the lower part of the back. And that was at least abolished some of his symptoms temporarily.
Yes. Okay. And Annette, what were you seeing that tipped you off to believe, this is nice and all, Tui's trying hard, but he's going to fail if he thinks that this is a derangement here? What were you seeing out of the patient that tipped you off?
Well, I think it was the pattern in the symptoms and what got the patient worse. I don't recall his better worse section. It was a few weeks ago, I think. But I remember the situation, and but I also said to Tui, if you're not sure, you need to test it. And he did, and he got the answer that he was not classifying the patient with a derangement, but with the mechanical unresponsive radiculopathy syndrome.
Yeah. So you're saying that more from the history, you were hearing there's hints there.
Yeah, and also when you test the baselines, if the patient did not want to do the extension and the side glide and standing, and I think he was worse also with flexion and standing, wasn't he too?
Yeah, it was.
With a positive SLR, a straight leg raise. So I think it was the pattern, and we had a discussion, when do we need to stop pursuing this derangement? When is enough? So I think that's one of the processes both Tina and Tui are going through at this point. We need to be sure. And what does it take for us to be sure that we tested it all? Also to reject the derangement classification. We all like the derangements. Yeah, we do. But in this setting, Tui and Tina, hopefully they will experience that they can spot the ones that are not derangements, and they can also help those patients. Yeah.
Yes. Yeah. So you hear that so commonly from those that are diplomats, and their efficiency, or how quickly they can get to those answers, seems to improve over the time as they stay and adhere to these principles within the system. So maybe that's what I'm hearing from you, that Annette, you kind of picked up on it a little sooner than Tui, and I bet maybe Tui's now in these more recent weeks would pick up on it quicker as well, perhaps.
I think he will. Yeah.
Tina, talk to us about some of these challenging patients that maybe don't fit into these derangement, dysfunction, postural, this challenging other category, maybe chronic pain patients or patients that just aren't responding to anything, and how challenging it can be to test and test and test, and the patient comes back the same or worse, and they come back the same or worse again. Do you have a patient in mind? Talk to us about that, and whoever the instructor was, maybe we can hear from their perspective as well.
Well, yeah, I've seen quite a lot of those chronic pain patients. That's why you're asking me. I know that. Yeah. And yeah, they are hard to deal with because you cannot move them a lot. You cannot make them better in a short time. And yeah, that's hard to work with. And I was struggling with the thing that I wanted to make them better, and well, that wouldn't change that quickly, and that was frustrating, realizing that I can mainly just guide them more than I can fix them. Yeah, So I don't think I need to talk about anyone specific because I've seen, difference of them.
Yes. Klaus, maybe you've been with her on a patient or two that have been in the other category, and maybe it's something that you've seen in yourself or with Annette when she was going through the diploma program. When we have these patients and we have that tendency to want to make them better, what are the flaws in that?
Yeah, first off, you have to recognize when you see a chronic pain patient, and if you see enough of them, then you know pretty fast in the history. The next thing I think is we as clinicians need to get out of the role of making people better. So we have to start off being a diagnostician. We have to find out what's wrong here, what's going on. And it's not our personal thing. It's not us as a person who are failing. We just need to find out what's wrong, and we need to keep a pretty straight face and stick to the system. But it's hard, you're sitting in front of a patient who is in real agony, and you are empathetic and you listen to them, and obviously you want to make them better. But making them better might be a long process, and maybe the process has to go along with you have to deal with your pain and start setting goals for your functions instead. So that's a really hard process. And to be fair, you're in this setting where you also need to stick by all the rules. So you are thinking about, what do I need to do? What do some people want me to do? And it's really tough when you have these patients, because maybe at your own clinic, you just talk to them. Maybe just have a talk. And then the next time you do something else. But here we expect something of you, and it's hard. It's hard. And I know for Tina, the patients we see are just by flip of a coin from the secretary. And she has seen her fair share of chronic pain patients. And then when you have 2, 3, 4 of them, you want to see some other patients where you get the success stories. But, I've been talking a lot about it's not that way you measure your own success. And we don't expect her to make anybody better with a chronic pain syndrome, because maybe you can't.
Yeah. Well, I know that that's a challenge, and it brings a few papers in my mind. Tina, too, you recognize these from the theoretical about looking for what's the dominating driver of this pain and disability. And so, yes, there may be a mechanical piece to this patient, but is the more significant portion of why this person is in pain and feeling like they can't function well because of these cognitive, emotional, or contextual things. So maybe, Tina, you're seeing the combination of what we learned on paper in the theoretical and now how you're seeing patients with these problems come together.
Yeah, of course, I've always met these patients in my own clinic as well, but I think I've got a better tool by now because I've got to know about these drivers of pain and disability, and I can use them more actively. And perhaps talk to the patients about those concerns as well.
Yeah. Tina, whoever wants to handle this question, or maybe both, you've got just a couple of weeks left. What are those pieces still in your mind? You're like, I don't know that I'm ready or that I'm diplomat level in this particular area. Are there any areas that come to your mind? Tu, you want to handle that first?
Oh, it's difficult, Jason. I think there's so many different objects to pick up at here because it's a process in several different directions. So you got this one clue about it's not a brilliant idea to push your pen all the time. You got this brilliant idea that you shouldn't say every time you speak. You got this, how do you place yourself in the room? Where do you stand? How do you sit? How do you... And that's just the smaller parts, right? We all want to focus on the clinical reasoning and addressing how to react on drivers of pain and how do we perform our mobilization techniques, all that stuff. So it's just one big bowl of different parts right now, and it's a bit confusing to walk around in it, right? But I think one of the best pieces to keep going in the process is to follow up on our patients, is to see the third, the fourth, the fifth visit, how has the development been, and to pick up on the baselines, pick up at the history, and to see, are there any changes? How do we react on the results we get? So I think that's the most exciting in the next 1 or 2 weeks for me.
Ina, what about you?
Yeah, it seems as if it's a big puzzle and you've got all these bricks and you want to put them together, and I'm about to see what the picture is going to be, I think. Yeah. Mm-hmm. So, but I'm still missing some of the bricks in there.
Mm-hmm. Yeah, Claus and Annette, when you hear Tui and Tina mention what they're thinking about these last 2 weeks, what does it make you feel like you want to clarify for them or just talk about?
Well, we just had a talk like, I think an hour ago. I'm here with Tui and Tina today. So 1 hour ago, I told them this has been a very nice week. They've done very, very well. And you know, when you start off saying that, you always know there'll be a but. So right behind Tina, I don't think you can see it there on the screen, but just told them, just remember how you got here. You got here by learning all the basics. So they have all the pieces in the puzzle. Now they need to stick to all the basics. So keep on producing good baselines, do good retesting, do good clinical reasoning, and so on, because that's what got you here. They've done so well this week. So I know for myself, then suddenly you think you can shortcut everything and outthink everything, but you just need to stick to your basics. Then you can be excellent if you stick to your basics. If you're the best baseball player in the world, you still do the drills on the basics, because that's what got you there in the first place. That's what we all got to remember.
Yeah, good. Annette, what would you add to that?
Well, I think Tina and Tui, they should focus on also that it's quite normal to have this lot of pieces and they cannot put it all together. And so I think it's fair that they are saying that at this point. And maybe they would feel more that the puzzle is more united at week 9. But after week 9, they should continue working with the basics, like Claus is saying, and keep focusing on the parts of the puzzle where the patients, they don't fit in all our boxes. And so they should continue working and refine the parts of their clinical reasoning so they can be prepared for the exam waiting at the next level. So
yes.
Yeah. Mm-hmm.
Yeah, excellent. Well,
but I agree with Claus with all of that he's saying.
Yes, in the midst of it, I know that's the same way I felt. Tui and Tina is like, okay, I think I got some of this, but I'm just not sure I'm at that level where I want to be at this point. But I think we can all agree that this is never ending, right? Even after you get your diplomat level, if we are so successful to do that, it's an ongoing process. So it's been very great to hear Claus, you and Annette mention about the program and the intention and how the day is formatted. Tui, thanks for joining us. Tina, thanks for coming back and talking about your experience these first 7 weeks, and only 2 remaining. So hang in there. And then you get this time where you're like, oh no, now I have to study and prepare for the exam. So It's not over after this, but we understood that coming into it. Thank you guys for taking time out of your day, for carving in a little time to speak with us and kind of bring us to speed on where Tui and Tina are. I appreciate you guys joining the podcast today.
Thanks for having us.
Thanks, Jason.
Okay, so there you go with episode 397. It's nice for me to hear how Tui and Tina are experiencing some of the same changes and developments in themselves, which I also recently saw in myself in my clinical as well. Stay tuned for additional candidates as they make their way through the 9 weeks of this second portion of the program. That's coming up next episode. Don't forget to subscribe to my email updates to be notified of new episodes. You can do so by clicking on the sign-up bar at my website. Subscribe to the podcast on your favorite podcast player and follow me on my social media channels, as we'll be notifying you when each episode comes out. If you're hearing this audio version, do know that we're releasing a video version of the podcast on our YouTube channel too. Again, we want to thank today's sponsor, the McKinsey Institute International, providing worldwide training and support to clinicians in the principles and practice of the McKinsey method for the management of patients with spinal and extremity disorders. The McKinsey Institute Diploma Program provides the highest level of MDT training. It enables clinicians to acquire an in-depth understanding of the McKinsey method and become experts in its effective use in guiding their patients to achieve their personal goals. If you have an interest in learning more about the diploma program, check it out at mckinseyinstitute.org. And if you've heard enough and you're ready, you can apply to enroll in this program through the mckinseyinstitute.org through October 31st of each year. By the way, we're continuing to plug away here at the Mechanical Care Forum with new cases within Case Conversations. That's our patient case discussion resource. And new scientific studies within Inside the Science, our peer-reviewed summary and discussion resource. Currently, regarding Case Conversations, we're highlighting the topic of subgrouping within the classification Other. Are you considering subgroups like chronic pain syndrome, inflammatory arthropathy, mechanically unresponsive radicular syndrome, spinal stenosis, SI joint or pelvic girdle pain, and other subgroups within Other as you classify? If so, are you confident in the keys of management within each group? And within our research resource, Inside the Science, we're spotlighting papers on a systematic review of centralization and directional preference and the prevalence of centralization and directional preference in patients with spinal pain with Dr. Stephen May. These resources, Case Conversations and Inside the Science, are intended to provide some virtual mentoring for you and help keep you moving forward in your professional development. They're separate from the McKinsey Institute, just something we do here at the Mechanical Care Forum. You can check these out at mechanicalcareforum.com. All right, I wish you a great week with your patients this week. Pursue practical, collegial case collaboration. And join us right back here next week for more from Season 13 and sharing experience for improved patient care.